increasingly affecting and percolating to all the social and economic strata as it happened in our patient. And this case was also selected on the basis of feedback which was received from the faculty as well as PG students that we need to discuss the diabetes and certain shortcomings were identified. And with this, we close. And thank you for a patient listening. And we would welcome a feedback so that we can improve a static clinical meeting from Department of Internal Medicine. Thank you. Any questions from the residents, please?
So let's say a patient comes to us in OPD who's already on 3 oral anti-diabetic drugs on maximal dosage and he's still uncontrolled. We plan to start him on insulin. So once we start him on insulin, what should we do with the other oral anti-diabetic drugs? Should we taper them down, reduce them and just put him on insulin, or should we continue the drugs also?
So basically uncontrolled sugar, very good, very good. So basically what happens is, how do we start the insulin? The guidance says that you start with 10 units basal insulin whenever instituting the insulin in a very well stable patient who's not controlled, is not into emergency or catabolic state. You can start with 10 on that is an add-on to the treatment. You need not taper down this. But remember one more studies and which we discussed in one of the study lessons in a department also. When you add the third anti-diabetic drugs, your that benefit with respect to the HbA1c is very, very minuscule. In fact, the fourth anti-diabetic drug, it is almost a nil. So beyond 3 anti-diabetic drugs, it will not make much of a difference. So uncontrolled diabetes with your anti-diabetics, you can add a 10 units of insulin without any decreasing the dose of other anti-diabetic. But having said that, you should remember the mechanism of action, because sulfonylurea also is a secretagogue and you are giving an insulin. So the combination is not a logical thing which is in such a scenario. Sure.
Sir, in admitted patients, sir, when we are doing continuous blood sugar monitoring, all the values are within 250 to 300. Suddenly, 1 or 2 values ranges above 300 or 400. There is a habit of giving a correction dose. Is it actually indicated, or what is its implication on long-term management of diabetes?
So it is the inpatient management of diabetes is a very extensive topic. But remember one thing: whenever the patient is admitted or is critically, try to achieve a target of around 140 to 200, or you may be little liberal of 150 to 200. And so in these, that is, having said that, so target should be understood. But if the patient is having uncontrolled parenteral insulin, then if you give a correction doses, please add that correction doses to next day insulin.
Sir, in case in pre-anesthetic checkup, sir, we are getting a referral from other departments for fitness for surgery, sir. So is there any criteria cut off the fasting PP or postprandial sugar so that the surgery can be done that level?
So whatever the Department of Anesthesia is doing, they're doing the correct when they refer it, because hyperglycemia, we have a robust evidence available that hyperglycemia can have uncontrolled can have a very, very adverse outcome. But then you have to stratify what kind of surgery your patient is going on. With patients very well controlled, again, I would stick to 140 to 200, 7% HbA1c is the perfect patient to be given fitness. And if the patient obviously if it is having uncontrolled diabetes and the patient the surgery is elective, you will make an attempt to control, because that would translate into better surgical outcomes also with respect to that patient. So that should be understood. But always remember, whenever it's emergency surgery, any glycemic control can be controlled with insulin infusion. So patient is always fit with that perspective. Sir,
last question. Sir, in a patient with not in acidosis, sir, at what level of glucose we should start with insulin infusion, sir, to check the requirement of insulin?
So there are two things to it. So basically, you're using insulin. He is asking insulin infusion to decide the dose of your subcutaneous insulin. So this is a common mistake which happens. So the patient was at 700 blood glucose, and we gave him insulin infusion for 12 hours, and his glucose was 300 to 400. And in the early morning, it was 120, and we said that now patient is controlled, and the basis of the last 12 hours insulin, we calculated his subcutaneous insulin. But that is not a correct strategy, because that was a glucotoxicity state of insulin. So patient should be having an appropriate, should be free from glucotoxicity, and those 24 hours insulin dose will be corrected, and give 80% of that as a subcutaneous insulin, half as a basal dose and half as a parenteral dose. Parenteral means rapid acting. So any comments from the faculty? So please.
Sandeep very nicely discussed. You have brought out a very relevant topic in this forum. I just want 2-3 points for the residents. When we are treating diabetes patients, it is not just the drugs which are important. It is the counseling to the patient which is more important. It is a diet management which is more important. Unless and until we control the diet of the patient, we may give any kind of drugs, we may give any amount of insulin. The sugars are not going to get controlled. The first and the foremost treatment is the diet control. Patient has to be explained what kind of diet the patient has to take. Because if the patient is taking such kind of a diet that he increases his blood glucose to 500 milligram percent with drugs, any kind of drugs, it is only going to come down to 300 milligram percent. It is not going to get controlled. So diet is one therapy which is the most important and the cornerstone therapy in cases of diabetes management. And it has been seen that no drug brings down the HbA1c as the diet brings it. Diet brings down the HbA1c down by about 1.5%. And second is the exercise. Exercise brings down the HbA1c about 0.7 to 0.8%. So with diet and exercise only, we are bringing down the HbA1c by about 2 to 2.5%. So we should spend some time with the patient, 5 minutes with the patient who is newly diagnosed with diabetes, explain the diet to the diabetes. Only thereafter comes the dietary the drugs. And as far as drugs are concerned, there is no fixed prescription for a diabetic patient now. The drugs are all individualized. Every patient will be given a different set of drugs based on what kind of comorbidities the patient is having, what is the age of the patient, and whether the patient is obese or not obese, or whether the patient has atherosclerotic cardiovascular disease. So the drugs, the insulin will vary according to the patient. There is no fixed prescription for the patient. So look at other comorbidities, look at the weight of the patient, and then decide about the drugs management.
Thank you, sir.
Excellent presentation, Sandeep, involving each and every specialty, especially. Just a one point. Generally, we know that in diabetes cases, we have a normocytic normochromic anemia. But whenever there is a very high rise of the sugar, or because of any spurious cause, also taking the sample from the IV line where sugar has been manifested, we often found macrocytic hypochromic RBCs or anemia. And generally, we go into that. Unnecessary investigations are being ordered because of that. So I request everyone that basically if that scenario is there, then one can repeat once the sugar level goes down, because it is often finding.
Thank you, sir. That point is well taken. Sir, any final comments from you?
I think very well covered and comprehensively discussed. And a very common topic and very relevant topic, especially in our scenario where India is supposed to be the capital of diabetes in the world. And there are monograms written on each and every aspect of diabetes. So I think in today's lecture, I think even if you've got a stimulus to about each aspect regarding starting from how it starts, what are the types and things like that, I think job has been done, very well conducted. And my only one small thing as regards the service implication, what do we do for patients who come with a fasting of say 120 and a postprandial of 91, as you rightly said? What is, because there's a very common thing, they come for medicals and they come with this report. What do we do?
So we label them impaired fasting glucose and we put them in appropriate category.
In category or it goes in shape? And that was because
so
he says that both are
category.
normal, so why should I be in category?
And officers can be put in 1B, sir. So with this, we come to end of today's Saturday clinical meeting. Thank you, everyone.